Hello everyone, and welcome back to the channel. Before we dive in today's lesson, a quick word about consultations. If you'd like personalized medical advice, you can find me on Telegram at My Private Doctor. It's not a channel, but my direct line for one-on-one consultations. The link is right down in the description below, so feel free to reach out. Today, we're exploring hemophilia, an X-linked bleeding disorder that mostly affects males. Let's start with the basics. There are two clinically similar types. Hemophilia A is the more common form, caused by a deficiency of factor VIII. Hemophilia B, also known as Christmas disease, results from factor IX deficiency. About 1/3 of all cases actually arise from spontaneous mutations. The most serious complication is intracranial hemorrhage. It remains the leading cause of death in these patients. Because of their bleeding risk, individuals with hemophilia should avoid NSAIDs, intramuscular injections, and any invasive procedures whenever possible. Pre-hospital care. If you encounter someone with hemophilia who's bleeding, rapid transport to definitive care is crucial. Apply direct pressure to any active bleeds immediately. And if you have access to clotting factor replacement, use it during transport. For hemathroses, bleeding into joints, remember the RICE approach. Rest and protect the joint, apply ice, elevate it, and use crutches for any weight-bearing joints. Clinical features. The most common bleeding complaint in hemophilia is hemarthrosis, or joint bleeding. In pediatric patients, the ankle is involved in 80% of cases. In adults, the knees are most often affected, followed by elbows and then ankles. Repeated hemathroses lead to chronic joint damage if left untreated. Next, hematomas. These are deeper soft tissue or muscle bleeds. They can occur in the neck, risking airway compromise, in the limbs, where they may cause compartment syndrome, or in the retroperitoneum, leading to massive blood loss. Mucocutaneous bleeding is uncommon spontaneously, but CNS bleeds are unfortunately common and are a frequent cause of death. Subdural hematomas can occur on their own or after only minimal trauma. Hematuria, or blood in the urine, is also common, but usually not serious. Differential diagnosis. When you see bleeding, consider other coagulopathies, platelet disorders, von Willebrand disease, and acquired factor deficiencies from anticoagulants like warfarin, heparin, or DOACs, as well as vitamin K deficiency, disseminated intravascular coagulation, or liver disease. Genetically, you have to think about hemophilia itself, factor inhibitors, or lupus anticoagulant. Evaluation laboratory tests show a normal PT and a prolonged PTT, unless it's a mild case. A mixing study will correct the PTT if no inhibitors are present. Definitive diagnosis and severity assessment come from specific factor VIII or IX assays. Imaging is guided by clinical signs, head CT or MRI for any headache, altered mental status, or trauma. CT of the abdomen and pelvis for pain in the back, thigh, groin, or abdomen when you suspect bleeding. Clinically, any pain in soft tissue in a hemophiliac patient should be treated as bleeding until proven otherwise. Paresthesias may point to a retroperitoneal bleed, and a flexion contracture of the hip suggests an iliopsoas bleed. Severity classification by factor level. Mild, factor activity above 5%. Bleeding usually only after trauma. Moderate, factor activity between 1 and 5%. Bleeding after minor trauma. Severe, factor activity below 1%. Spontaneous bleeding is common. Treatment. The cornerstone of therapy is factor replacement. For hemophilia A, factor VIII, dose or weight in kilograms, X desired percent increase, X 0.5. Remember that 1 international unit per kilogram raises plasma weight by 2%. For severe bleeding, aim for an 80-pound, 100% factor level. For moderate bleeding, 30 to 50%. For hemophilia B, factor 9, dose, weight in kilograms, x desired % increase. 1 IUQ raises plasma 9 by 1%. Your target levels mirror those in hemophilia A. Let's walk through site-specific targets and dosing. All doses in units per kilogram. Joints. Acute level 80%, maintenance 40%. Hem A 30 units per initial, 20 units per maintenance. Hem B 16 units per initial, 40 units to maintenance. Muscles target 40 to 50%. Hem A 30 units per daily. Hem B 30 to 60 units key initial, then 20 to 30 units kg maintenance. Oral bleeds 100% hemostatic level. Hem C 50 units kill. Hem B 100 units. Nosebleeds initial 80 100%, then healing level 30%. Hem A 40-50 units Q initially, 30 to 40 daily. Hem B 1600 units Q initially, 35 to 40 daily. GI bleeds 100% initially, 50% for healing. Hem A 50 units Q initial, 30-40 daily. Hem B 100 units Q initial, 30 to 40 daily. Genitourinary bleeds same as GI. Hem A 50 units Q initial, 30 to 40 daily. Hem B 100 units Q initial, 30 to 40 daily. CNS bleeds 100% initial, then 52 to 100% for 14 days. Hem A 50 units Q initial, 25 units Q every 12 hours. Hem B 100 units Q initial, 50 units Q daily. Surgery or trauma 100% initially, then taper. Hem A 50 units carried initial, 40-50 units Q every 12 hours. Hem B 100 units co-initial, 50 units co-daily. If the diagnosis is unclear, fresh frozen plasma can be used. It contains both factors VIII and IN and raises levels by about 3 to 5%. Adjunctive treatments, desmopressin, DDAVP, at 0.3 micrograms per kilogram IV over 15 to 30 minutes is useful in mild hemophilia. Antifibrinolytics like tranexamic acid, TXA, help control oral mucosal bleeds. And as always, avoid intramuscular injections. Inhibitors to factors. If a patient develops antibodies against their factor concentrate, management becomes more complex. You'll need a hematology consult. Salvage therapies include recombinant activated factor 7A or activated prothrombin complex concentrate, FEIBA. Management considerations: treat bleeding immediately. Don't delay while waiting for lab results. Early factor replacement prevents delayed bleeding. Reassess both factor levels and clinical status frequently, and avoid invasive procedures until factor levels are optimal. Keep a close eye on any large hematomas for signs of compartment syndrome. Disposition: admit patients who require multiple factor doses, have bleeding in critical areas like head, neck, airway, or retroperitoneum, or are at risk for compartment syndrome. Patients with mild hemarthrosis, no active bleeding, and who've received prophylaxis may be discharged with close follow-up, coordinating care with their hematologist or primary provider. Thanks for watching. If you found this overview helpful, give it a thumbs up and subscribe for more medical insights. And remember, if you need tailored advice, ping me on Telegram at My Private Doctor. The link's in the description. See you next time.